This Week in Parasitism is brought to you by the American Society for Microbiology at microbeworld.org/TWiP. This Week in Parasitism, episode number 91, recorded on June 18th, 2015. Hey, everybody. I'm Vincent Racaniello, and with me is Dickson Despommier.
Hello, Vincent.
And Daniel Griffin.
Hello, Vincent, Dickson, and everybody.
And Daniel, of course.
Cloudy day today, isn't it?
It is out there. It was a beautiful day yesterday as I mixed it up with the trout.
19 degrees Celsius.
Yeah.
You know, I did a couple of podcasts in Scotland, and they had no problem with Celsius for the weather.
I can imagine.
Do you have a problem with Celsius?
None.
Do you, Daniel?
No problems.
But when you take temperatures, it's always in Fahrenheit, right?
You know, we've talked about this in the hospital, and whether or not someone has a fever actually depends in people's mind whether or not you're using Fahrenheit or Celsius, because in Fahrenheit, right, if it's above 100 degree, but then in Celsius, the cutoff is 38 maybe,
right.
Or maybe even. But anyway, we've had discussions about what do you consider a fever, and the audience responds differently. The clinicians respond differently to what units you're using.
Right.
All right. I want to read a follow-up email before we start. Dickson, you don't have your thing. Is that okay?
Oh, I don't have my thing. That's okay. I can look over his shoulder.
All right. It's a follow-up from Heather. All right, Heather writes, Dear Doctors R, D, and G, I really hate to criticize learned professors, especially my elders. Actually, you should. A professor is
you should always question authority.
It's okay.
Always
as long as you are nice about it, right?
That you have to do it collegially.
I suspect I may be being overly sensitive, or perhaps it is a cultural difference. However, the over-talking is decreasing the quality of the TWiP podcast. I think the quality would be improved if certain hosts made a concerted effort to not speak over other hosts, but to pause and insert their wonderful insights, which I really do want to hear only when others have finished speaking. I know it is hard to teach an old dog new tricks, but the over-talking makes the discussion hard to understand at times. Please don't be offended. I love Twix, especially the party guilty of over-talking.
Which over-talker is she discussing?
Hesitantly, Heather. Well, she's being very...
Because there are three of us here.
She's being very...
diplomatic.
Exactly. I'm at a loss for words today.
That's okay. We'll help.
And I appreciate that. We should all just be mindful of over-talking.
It's a decorum issue.
Here's the thing. When someone is talking, just wait for them to finish. That's what I'll try and do. I know I often interrupt. Because I'm so interested in learning.
No, it's enthusiasm that drives this. And so, therefore, it's not out of impoliteness that you're doing it. Is you want to get to the next point.
I think it's enthusiasm for sure. So let's
absolutely.
All right.
Could I jump in and say that I'm really not that old, because I see that I was caught by especially my elders.
So it's me and you, Dickson.
It must be
me, because I'm going to be the oldest one here.
Are you less than 50? No.
I am less than 50.
Oh my God, this guy is a youngster.
I am a youngster. Yes.
He's the junior partner of this operation.
You're less than 50.
Yes.
Wow.
I'm a young man.
That's incredible.
You have many years left.
He does.
Okay.
Good. I hope I have many.
I don't think you are guilty, Daniel, at all. You never cut anyone off.
It's got to be me.
He's a good physician. He listens.
That's true.
And waits for the patient to be done. And
absolutely.
Then he says his thing.
He does.
And his thing is, that'll be $100.
That's right. Send it to my group practice. I'll be in Hawaii.
All right. We had a lot of responses to last time's clinical case, which was over 2 weeks ago because I traveled last week.
Right.
And the first one is from Anne.
Now, I will jump in and say, remember we came up with the idea that we should refresh everybody?
I'm sorry, I forgot.
So, no, that's okay.
Refresh us, Daniel.
Let me refresh.
Please.
There will be some refreshing.
He judiciously interrupted me.
Did I interrupt well? Did I do that well?
Fine. I don't mind.
That rambunctious youngster.
Okay, as some of our listeners will hopefully remember, or for those of us that are tuning in for the first time, we presented a case with a 28-year-old man, and he had come to medical attention after 2 weeks of headache a low-grade fever, some change from baseline in his, as we said, mental status. That's his cognition. Weakness in the left arm. He had been brought to the hospital on Long Island by his friend when his friend, his male partner, had noticed that he had fallen to the floor and had a shaking motor episode, which we described as consistent with a seizure. I think that's about all. I don't know if we had discussed any imaging last time, but
that's it. Right.
That should refresh everybody.
We stopped at that point.
And then we did establish that he was bisexual, had many partners, and practiced unprotected sex, right?
Yes.
Right.
Actually, I had 2 other follow-ups I forgot to read, but we'll save those for later. Here are the case 90 emails from Christine, 28-year-old patient, suggests to me of a multifactorial diagnosis. The candidate in an adult suggests reduced immune function. Given his sexual history, I'm concerned about HIV, and both he and his partner should be tested. As a consequence of reduced immune function would be an increase in risk of toxoplasma. This may cause focal brain lesions that can explain the weakness, seizure, and behavioral mental changes. Given the seizure, an MRI or CT would be my first instinct, with serology for toxo, a blood smear for the presence of active infection. If indicated in the scan and supported by blood work, I may request a lumbar puncture to do PCR for toxo in the CSF. Given that toxo is such a successful parasite and the initial infection can be asymptomatic, it's likely he's encountered this parasite possibly without knowing it. Treatment for toxo candida and if diagnosed HIV should begin promptly. The weather here in Brisbane is partly cloudy, 24C, predicted max of 28, 30% chance of rain, moderate UV alert, and a low moderate fire danger. Beautiful late autumn day. It's hard living in paradise. Christine from Brisbane, enjoying my Sunday morning TWiP.
Great.
It's like coffee, Sunday morning TWiP.
Yeah, you got it.
Okay, Daniel.
Jan writes, "Hi, sportsman. What better way to spend a rainy Sunday afternoon than trying to solve a puzzle using one's brain instead of shutting it down in front of the TV watching a game? Especially since I'm on a winning streak in my personal league. The pinworms were foul play." Daniel didn't want to give the results of the blood tests, but I'd be surprised if the guy didn't have HIV/AIDS. Do his toxic habits include needle sharing when using intravenous drugs? Not that it matters. The unsafe sex, probably including anal, with multiple partners is dangerous enough of its own. Combining the presumed AIDS with the symptoms leads me to think it's toxoplasmosis. My cats agree, and they're never wrong. Greetings, Jan. P.S. Congratulations to Vincent on the pronunciation of my name, and I don't watch sports, not even the stereotypical ones.
Dickson,
I'll
you're
read
going to
the
be
next
able
one,
to
but
read.
I'm going to have to share the computer. All right. Elise writes, Dear TWiP trifecta, I hope all is well. It is soggy and stormy and suddenly chilly. 56F, 13C. She gives both interpretations. Here in Lower Manhattan, as I am sure it is for you all uptown. For once, I almost hope my diagnosis is not correct, because if I'm right, this is a sad one. This diagnosis was tricky for me, and as a result, in multi-part, but I must say first that all of the clues suggest to me that the patient has toxoplasmic encephalitis or cerebral toxoplasmosis. I'll try to explain my thinking. The first thing I sorted out was that the patient's symptoms seemed most like a form of encephalitis. Personality behavior changes, left side weakness, seizure, persistent headache, low fever. I got a bit stuck trying to figure out what sort of encephalitis he might have, because most of the parasites that wind up in the brain didn't fit the profile of this patient, especially given that he has not left the United States and doesn't have other lifestyle changes or choices that might expose him to some of the parasites that you have discussed in other patients, like tapeworms, for instance. While I was slightly stymied by the encephalitis, I set it on the back burner and looked at some other symptoms. I was intrigued by the patient's non-encephalitic symptom of having a white coating on his tongue and lacy white mucosa in his mouth. This sounds quite a bit like thrush, oral candidiasis, which can be a symptom of an HIV infection, and suddenly a lot of things made sense.
I will help you
have
there
to scroll.
with the
Thank you,
scrolling.
Mr. Scroller, the prompter, right? The patient maintains a high-risk lifestyle that could lead him to having contracted HIV. He has a lot of sexual partners for both sexes and admits to not taking any precautions to protect himself from sexually transmitted diseases. In addition, he uses recreational drugs, and while you didn't mention whether he injects himself, if he does, this is another unsafe behavior that could lead to a lot of infections, HIV among them, if the patient is HIV positive or otherwise has a diminished immune system. No, read that again. If the patient is HIV positive or otherwise... No, I read that correctly. Or otherwise has a diminished immune system. Many, many healthy people have toxoplasmosis and are entirely unaware of it. Literature tends to describe these infections as latent and asymptomatic. When, however, the body's immune response is compromised, the Toxoplasma gondii protozoan parasite can become reactivated, and if they are in the brain, cause lesions that trigger the encephalitis symptoms. Since the patient has not been to a doctor in quite some time, it is possible that he doesn't know about his HIV status and that all of these symptoms are a horrible surprise. I would be very interested to hear how the toxoplasmic parasite reactivates without a strong immune response to keep it in check. How does it remain dormant? This was a tricky diagnosis, so I'm prepared to be wrong, but I am very much looking forward to hearing whatever the answer may be. As always, tons of thanks for your wonderful work. I await your next podcast on the edge of my seat. Many best wishes.
Next one is from Shane, who's in Queensland. Yeah, we have quite a few Aussies here listening.
We do. That's
My
great.
guess is toxoplasmic encephalitis caused by T. gondii coupled with HIV infection. Giveaway was the very active, unprotected sex life with multiple partners. Weather in Queensland, 20 degrees C as you entertain me on my commute home from the University of Queensland.
Which is in a beautiful place, by the way.
Daniel.
Eric writes, Dear Dickson, Vincent, and Daniel, I am writing with a guest for the case of the week from TWiP 90. But first, let me say, a long-time listener but first-time caller, or writer, that I find your podcast sensationally well done and informative.
Wow.
I started with TWiM several years ago when I finally got a smartphone with a good podcatcher. I moved to TWiV after exhausting TWiM's back catalog around the time of the most recent Ebola outbreak, and then later discovered TWiP. I love to learn and find it brilliant that I can turn commuting time and driving the kids around town, which otherwise feels wasted, into learning time with Twix episodes. My degree is in astrophysics, but I have since moved to the field of proteomics and have picked enough biology to follow along even when you dive deeply into the papers, mostly. Regarding the case of the 28-year-old man with the seizures, the information is rather limited, but for the huge advantage to know that the answer must involve parasitism. I strongly suspect that this is a case of encephalitis caused by toxoplasma. Since this gentleman reports unprotected sex with multiple partners, he must be considered high risk for HIV infection, and I fear he might be immunocompromised due to early stages of AIDS. Toxoplasma is in an immunocompromised individual may well cause encephalitis that can cause the symptoms described. This was the case with tennis star Arthur Ashe, who then founded the Arthur Ashe Foundation for the Defeat of AIDS. The first questions I would like to answer are the lymph nodes swollen? Then is he HIV positive? And then a test for toxoplasma. Perhaps there's a good PCR test. A question for you. Would the signs and symptoms be any different for a new toxoplasma infection in an immunocompromised individual and a long latent toxoplasma infection becoming active with the onset of immunodeficiency? I love TWiP. The new case of the week with each episode is a great idea. It turns a one-way show into a two-way experience. Brilliant! I started with episode 1 many months ago, and now I've finally caught up and can participate in the cases in real time. Today's weather in Seattle was pure June gloom, a.k.a. June-uary. January, a common pattern this time of year where a low, heavy cloud cover is drawing in from the ocean and hangs overhead all day. But the 10-day forecast starting tomorrow is nothing but sun. Summer in Seattle begins tomorrow. Best regards, Eric from Seattle.
Tomorrow. It's not summer here yet, is it?
Not next week. Marks the summer solstice. Varun writes, "Greetings, Provs. In relation to the paper discussed, I want to cite an earlier work, Patrick Duffy and colleagues identifying importance of CD55 and CD59 in malaria. The study found also that the CD55 and CD59 levels dropped with age of red blood cells. Maybe by using the CD55, falciparum is trying to get into those red blood cells that are much younger, which makes a lot of sense." In the podcast, there was a discussion on, is there a possibility of virus replicating inside red cells? As Vincent explains, for obvious reasons, such a lack of cell machinery, this doesn't seem to be possible, nor could I find any published examples. This has fueled some scientists to look into the use of red blood cells as viral traps. This has been tried with little success for HIV too. He doesn't mean little success or with a little success. I'm not sure which way to emphasize that. The second question that came up was, why do human red blood cells lose their nucleus during development? The answer is that red blood cells is mostly a bag of hemoglobin and nucleus, and the nucleus is expelled through a specific mechanism so as to accommodate more hemoglobin. Additionally, loss of nucleus makes the cell extremely flexible, allowing the red blood cell to move easily inside very small capillaries. The flexibility of red blood cells is also attributed to a protein called spectrin, problems with which lead to spherocytosis, leading to anemia. This automatically brings into question, why does some animals have nucleated red blood cells? The straight answer is, I don't know. Perhaps somebody can chime in. Oh, with respect to the case described, I want to ask, is the patient HIV and HBV? What is the patient's status regarding HIV and HBV? Bisexual men are known to acquire parasitic infections related to GIT, such as Giardia and Entamoeba. The only parasitic STD I know of is trichomoniasis, but I'm not sure if this is even a case of STD. I'm not able to correlate the case with any organisms to explain the symptoms described. Sorry, but no guess this time.
Interesting. He should mention spectrin.
Oh, yeah.
I think spectrum will come up today when we discuss
our
article.
I believe it will.
Rebecca, my guess for the case study is toxoplasmosis. And this has been a problem for the HIV/AIDS population. I'm a bit nervous that I've read too much into this case, but it was the only thing that made sense logically to me. Thanks again for the podcast. Try and summarize these quicker now, since everyone's sort of saying the same thing. Daniel.
So I'll try to summarize. Bjorn writes, "Dear Twippers, case of the week. I'll guess encephalitis caused by toxoplasmosis." And then he also suggests, assuming that he has HIV, he may be immunocompromised and on his way to developing AIDS. The actual infection he could have gotten from many places: direct contact with feline feces or through eating raw or undercooked meat. And then he has a bunch of things he would like to know. He'd like to know the T cell count, suggesting that if this was less than 200, then this could be consistent with AIDS. And then he says he also wants an MRI, wants imaging. And then he says, guess that's it. Love TWiP. I don't think I'll stop trying to work on the case studies, even if I don't find the right diagnosis every time. Best wishes.
That's what group practice is all about, and that's what this is the program for. This is a group practice for explaining all of these things, right? Why don't you take the next one also?
Let me do the next one. He mentions Brazil, and we'll come back to that, actually, maybe. Dear TWiP Triforce, and he's a PhD student in immunology in Berlin, but originally from Rio de Janeiro, Brazil, where he did his bachelor's degree. I find them absolutely fascinating. Our TWiPs, I think, is what he's talking about.
Hopefully.
But I should get to the case. My guess is that the patient is suffering from complications of toxoplasmosis due to a weakened immune system caused by HIV. He also suggests that the white coating on the tongue might be caused by Candida. And he says if the patient really has AIDS, a low leukocyte count would be visible in the complete blood count, the CD4 T cell count, and serology for HIV would be helpful. Thank you all for doing this extraordinary, informative, and fun podcast. All the best, Alberto.
All right, the last one is from Robin. Left upper monoparesis, subacute mental status change, white coating, mouth and tongue candidiasis, seizure with post-ictal state, low-grade fever, toxoplasmosis, AIDS. That's basically it. You got. All right. Let's get to the
actual
case.
revealing the envelope, please.
What should we reveal? So let me.
Yeah.
I will now open the envelope.
Should we ask for more tests first, just to bring us up to date as to what we do next if you were not sure? Because we had a lot of suggestions about tests, and some of them involved biopsies and.
Is this your
taking-
patient?
Yes, and we unfortunately we still see more of these cases than anyone would like. Definitely more than I would like.
Yeah.
And a couple things to put it together. The patient did test positive for HIV.
May I ask you, was that the
That was
test you asked for immediately?
Yes,
I'm
and that
seeing
was
why did you ask for that?
It was really the whole story. The white coating on the tongue, and then I'll say the buccal mucosa, which is the inside of the cheeks, was very characteristic of Candida. And people often, when they feel crummy, they say, "Oh, I've got a white coating on my mouth." And you learn after a while to visually make the distinction between oral candidiasis, so Candida affecting the oral area, and just this sort of overgrowth of bacteria and that someone might get when they're sick. So this was clearly recognizable as oral candidiasis. And so here, we see a man who looks somewhat ill, looks weak. There's a lot that you just from the visual makes you think.
Okay.
And then as you discussed, he was high risk for this diagnosis. But I want to probably take a moment and say that in our clinic out at North Shore LIJ, 40% of our patients are female. There's this stereotype, and the media seems to be pushing it, that this is a disease restricted to men who are physically intimate with other men. And that portion of the population has been severely affected, but this is not restricted by any means to that population. But as we were, looking for cases, I thought that would sort of make it a little more reasonable as an unknown to give a patient who actually had that as a risk factor. What we did initially, what came back very quickly, is not the antibody test that we use to diagnose HIV, but we can actually do a quantitative PCR for the virus, for the HIV virus. And this patient came back with a viral load, a load of virus of over 100,000 copies per ml. So pretty high viral load. And that will feed into a little. The next thing we saw was that this gentleman's CD4 count, and this is CD4 cells per milliliter blood, was down at 25.
Ooh.
Yep. So
Wow.
now, and I want to sort of explain the units
What's normal?
there.
What's normal?
Normal is about 1,000.
Right. Wow. He's
And that's
low.
1,000 cells per milliliter. So you multiply that out, 1,000 for a liter, another 5 for the amount of body. People always say, "Oh, I only have 2 T cells." Well, I shouldn't say that. My patients often say things like that. But it's 2 T cells per milliliter, which really means 2,000, which really means, tens of thousands, etc. So this gentleman doesn't have only 25 T cells in his body. He has a count of 25 CD4 T cells per ml. Which, yes, as we were saying, is far below the normal of 1,000, far below the 200, which is AIDS defining, and actually below the 100 and particularly the 50, which is where you really start to get into a high risk of problems with things like toxoplasmosis.
Can I ask a question here at this point? In his physical examination, how was his lung function? Did you evaluate that at all?
I did, and why do you ask that?
Well, there's an infection called pneumocystis carinii, which is very typical for patients that have HIV/AIDS in the past, and that's treatable really very fast, right? So, did he come in coughing and wheezing?
No, he didn't, and actually, PCP, pneumocystis carinii pneumonia, we used to think it was a parasite, right?
Well, it's eukaryotic. It's a fungus.
And they've reclassified it as a fungus. Unfortunately, if they hadn't, I would have presented. I would love to present a case. It's very common.
Yeah.
And again, it's very common, particularly when the CD4 count gets below 200.
Right.
This individual doesn't happen to have that, but he is at very high risk for it. The challenge is it presents very differently. The PCP pneumonia presents very differently in the HIV population. It's this very long, drawn out, I've been having trouble breathing for weeks, where we'll see this in transplant patients with a much more acute onset. The challenge with the PCP diagnosis, we're going a little side here, is that the lungs usually sound good. The chest x-ray usually is normal. And one of the earliest ways of picking it up is you have them walk around the room and they become hypoxic. And so we'll often do that. You get the call from the ER at 2 in the morning. We got a guy, we're worried, and we'll say that. We'll say walk him around the room. And when he comes back, now he's dropped 10%. He's dropped from 91 down to 81.
Wow.
So this gentleman is at risk for that, but does not have any localizing pulmonary problems at this point. He did also have a serology. People asked about this.
Yep.
And the serology for toxoplasmosis, which a lot of people were concerned about, and that was positive. What he had right away, before any of these blood tests came back, was imaging, where they actually did imaging, initially a CT, but then a follow-up MRI of his brain. And I looked at these, and the CT, as well as the MRI, showed these called multiple enhancing lesions throughout the brain.
Right.
And, knowing that we're on This Week in Parasitism, the case is pretty easy. But when he came in, he didn't know he would end up, being discussed on This Week in Parasitism. So there is a bit of a differential. And one of the things we worry quite a bit about is CNS lymphomas. So these are cancers of B cells that present in the brain, and again, related to the immune system's inability to control. Usually Epstein-Barr virus is driving these. So this person could have been at risk for that, and these very well actually could have been CNS lymphomas. So the way we made the diagnosis, and the way we often make the diagnosis, is we presumptively treat. So we started the patient on treatment for toxoplasmosis because you really don't want to biopsy people's brains unless you have to.
Unless this treatment doesn't work, and then it was not toxoplasmosis,
and then you actually would, and often that's
right.
And that unfortunately has been the scenario in some cases. So this person was put on treatment for 2 weeks with repeat imaging, and at the end of 2 weeks, he was improving clinically and actually had reduction in the size of the lesions.
What's the treatment?
The treatment is sulfadiazine and pyrimethamine.
Yeah. There's a trade name for that too, right?
I'm sure there is. It's
called Bactrim, I think.
No, actually, it's actually different than Bactrim.
Bactrim.
Yeah,
Right.
Bactrim is a trimethoprim sulfate compound, so it's a little bit different.
If his lesions hadn't decreased, what would you have done?
If the lesions had not decreased, then often we would biopsy.
Right.
So I noticed, Daniel, you're wearing a specific kind of tie today.
Oh, I have my Mycobacterium tuberculosis
You
tie
do,
today.
and I've actually heard of grand rounds where that CT presentation turned out to be focal lesions from tuberculosis.
And I was hoping my bow tie would throw Dickson off.
And
There's a bit of subterfuge. Is that what that would
tried.
be? I tried. But no, and actually that in parts of the world, here maybe not as commonly, mass lesions in the brain can present. They could be due to tuberculosis. They could be due to syphilis. Right. Neurocysticercosis would present a little bit differently, in all honesty. You would see slightly different imaging. The CNS lymphoma. Part of what was a clue to this case is the focal arm weakness, which is really much more consistent with a toxo, which is really, as some of our writers mentioned, it's an encephalitis. It actually causes an inflammation and a direct destruction of brain tissue.
Right.
It really gets into the actual, say, parenchyma, into the brain tissue, as opposed to forming in the spaces and enlarging in the spaces between the brain. So in this case, this gentleman did reasonably well. About 2 weeks into treatment, he was started on his anti-HIV regimen.
Right.
The prednisone, the steroids, we didn't start up front. Some people will, but part of it is you're doing a therapeutic trial, and you don't want him to get better because of the steroids. Mm-hmm. So you want to see, because we're trying to save this gentleman from undergoing a biopsy.
Did you match the HIV antiviral to his genotype?
So that's a great thing in the modern world, is that before we start treatment on HIV patients, we will actually sequence the reverse transcriptase. We'll sequence the protease. We'll sequence, well, when you're doing the sequence of the reverse transcriptase, that's going to tell you which of the nukes and non-nuke drugs, the different reverse transcriptase drugs that you can use. And you can even now sequence the integrase. And so, I mean, I have to admit, this is one of the things I find fascinating about HIV. We send off the virus for sequencing. We then pick our drugs based upon knowing what the resistance is from the genetic code of the HIV virus that has infected.
And you do triple therapy, right?
And we do triple therapy.
So how many different triple combinations? As many as you want, although not all are available in a single pill, right?
Yeah, there are. That's the screensaver on the back of my on the desktop of my computer where I keep a list of all the. And if you think about how they work, it helps you remember these. So if you think about we're gonna block reverse transcriptase or try to interfere with reverse transcriptase. So one of the ways you can block it is by giving it different A's, C's, G's, or T's that don't allow it to continue forward, right? So there's a couple different choices of which A analog you might use, or C analog, or T analog. Probably everyone remembers AZT, which was a T analog. It was a fake T back, one of the earliest drugs. One of the most common drugs today is tenofovir, which is an A analog. It goes in as your A of your ACTG DNA code, but it can't continue forward. So we have a bunch of those. More and less, as more have come on the market, less are still on the market as we've gotten better, less toxic medications. Then we have a whole bunch of medicines that are really direct small molecule reverse transcriptase inhibitors, and they'll bind into a pocket that sort of prevents reverse transcriptase from working, and we sequence that section. Efavirenz is one of the most common ones in there, and then we have our whole list of protease inhibitors. Ones that are getting better and better over time are integrase inhibitors now. But there's a number, as you mentioned, Vincent, of single drugs. In a perfect world, we say take this one pill once a day. And we're actually getting more and more of those. Atripla is one that's very common. Stribild is one that lots and lots of people, these are the brand names because the actual generic name would be 3 or 4 drugs listed all together.
So if you...
Complera.
Can you make your own combination of any 3, or are only certain combinations FDA approved?
So I would not say that you can take any 3 and just throw them, because again, you wouldn't use 2 A's. You'd want to use like maybe an A and a C. You're going to use, often we talk about these nucleoside reverse transcriptase based therapies. Well, you'll use 2 of those, and then you're adding a protease inhibitor, you're adding an integrase inhibitor, or you're adding a non-nuke to that. The FDA has different medication combinations that are approved and recommended for initiation of therapy. But once you get past initiation of therapy, it's within the FDA usage to combine different drugs based upon the sensitivities.
And then you monitor, and presumably his CD4 counts went up, right?
So the first thing that will go down, and most rapidly, will be the viral load. And the viral load will drop very quickly, particularly if you have these integrase inhibitors. They really drop it. So there'll be a rapid drop in the viral load. Then once the viral load, then the CD4 count will slowly rise. And a lot of how quickly it will rise and the level to which it will rise has to do with the duration of the infection. A lot of individuals, if we can get them on therapy early, can actually restore to a CD4 count in the normal range. Even I had a woman with extensive tuberculosis to come into my tie, and she had a CD4 count down in the double digits like this. And last I saw her 2 weeks ago, her CD4 count had come up into the normal range.
So one of the early consequences of restoring CD4 proficiency, so to speak, immune proficiency, was an overreaction to the number of opportunistic infections that these HIV patients had acquired and had become tolerant to, so to speak. So now your immune system is at full strength again, and you've got a problem because now you're going to come down on them like a sledgehammer onto a fly. So are you not worried about something like that with this patient?
Yeah, we actually...
Because he's got candidiasis as well.
Yeah, there's a word for that, a name, and it's an acronym, but it's 4 letters. So it's an FLA, in fact, not a TLA, called IRIS, like the flower, IRIS, Immune Reconstitution Inflammatory Syndrome. And what will happen, and tuberculosis is, in all honesty, the worst culprit in this, is you start the patient on their HIV medications. The virus is being controlled, the immune system is coming back, and now you get this robust immune response to these different pathogens. And let's say this lesion in the brain had been a fungal infection, and you started to treat the HIV right as soon as you treated the fungal infection, say a cryptococcal meningitis. You actually would cause so much inflammation that you may end up being responsible for the demise of your patient. So as I was saying, in this individual, when I brought up we didn't give steroids, is for some reason toxoplasmosis does not cause as much iris as a lot of the other opportunistic infections, which makes it fine whether you start or wait 2 weeks. If you had a biopsy proven and said, I want to go ahead and start, you'll get less of this. But often we'll treat patients with steroids to somehow get through that severe inflammatory response. And in some cases, again, to use the tuberculosis because it's been so well studied, depending upon the level of the CD4 count, that will time when we start the HIV meds and the likelihood that they're going to end up in the hospital as we get their immune system reconstituted.
Yeah, so Daniel, you spent some time in Africa. I know this because we've had lunch together many times now, and you've told me about your exploits.
Yes.
When you have a patient in recovery from HIV that also has a smoldering malaria infection, because that leads us into our paper, is there a consequence in that direction also, like you've just described for tuberculosis?
There can be, actually. And the interesting thing is I should say that IRIS is not just restricted to treatment of HIV, but sometimes even if someone is so malnourished, anything you do where we bring back the immune system can actually create some problems. So there's a whole literature on the timing of bringing back the immune system and malaria and how they correlate.
Daniel, what color is an iris?
Well, that's a blue flag.
Apparently
iris.
purple.
That's a blue flag, but they're yellow. So I want the reader that sent in her decorum email to note that we've now gone to raising our hands if we want to make a statement.
That's what's going on over there.
No, you can go like, I have something to say, Mr.
Actually,
Remember Horshack? And
we'll probably go back to our old life. One episode.
Right.
So this gentleman will have a healthy life if he stays with his drugs.
That's going to be the challenge here is... we are hoping, and actually he has had very good recovery of the weakness of the left arm. So that is great. If somebody is diagnosed early and treatment is initiated early, I would say in some of the work that we've done and some of the literature out there, they can have a very good outcome. But unfortunately, even though we've now instituted, we say universal testing, everybody should get tested. It should be offered to everyone when they show up in the ER. Still, the majority of patients, when they're diagnosed with HIV, have CD4 counts below 200. So we're not getting there as quickly as we should. And part of it, I'm going to blame the media here, is there is this perception that this is a disease restricted to a certain segment of the population that the rest of us say, oh, that's the other, I'm not at risk.
Right.
But college campuses, as I mentioned, 40% of our patients at North Shore are female. The females are obviously not gay men intimate with other men, or MSM is the terminology.
It's weird because if you look globally at the transmission mode, it is by far heterosexual transmission.
No question.
In the U.S., it's not, but it's so biased. By
35 million people infected in the world.
Right.
Over 3 million children under the age of 5 who did not get it through.
Right.
They got it at birth, right?
Yeah.
Unwittingly.
So are you going to ask this gentleman to identify his sexual partners?
Well, so his sexual partner actually is the one who brought him in, who was taken care of, who was tested as well.
Yeah, but that's only one of them. You said he was bisexual,
Yes.
so he has other partners.
Was his partner positive?
Yeah, his partner was
So
positive.
you put him on therapy as well.
Right.
Yeah.
But they may have infected many other people.
Exactly.
Right.
Yeah.
Exactly.
Yeah, you don't do contact tracing, right?
No, not the same way. It's interesting. If someone came in with, say, syphilis or something, there's a whole sort of public health that triggers. This is a bit different. It has to do with history and politics, and so a lot of it is voluntary, talking to people and encouraging them to share their experience, their diagnosis, to get other people hopefully early diagnosed. Because, I'd say in parallel to cancer, if you can be diagnosed early, treatment started. Most of what it looks like is that those people can do really well, and maybe they could end up with your normal life expectancy. But unfortunately, if you wait too long, if we cannot get that CD4 count back up into the normal range or above 200, you probably can't expect to have a full lifespan.
So, Vincent, you might wonder what got me involved in parasitism to begin with. And what you're listening to today is an example of that, because there's a whole sociology associated with the acquisition of these infections. There's a biology to what they do to you. There's a biology of where they come from and where they're going. It's multifaceted. It just doesn't stop. And I'm sure that virology appealed to you in the same way. This could go on. I mean, we could have a 4-hour discussion on this and still not cover all the issues that are there. But, of course, we have to move on. But just know that the passion doesn't dissipate because it's about people. And it's about the environment. It's about the way life forms interact with each other. And I think that's the best way to look at all of this.
I think we did talk about why you got interested in the field a long time ago.
A long time ago.
I forgot.
Yeah, me too.
But it's there.
I know the original...
Episode 1, I think.
The thing that really riveted me to the spot was that guy with the shrunken head that showed up in our laboratory.
Right.
That was just the most amazing
Go back to
thing.
episode 1. You told that story. right.
I can still remember the day.
I can tell you that book, Lassa Fever, by
that's
John
right.
Fuller.
John Frame.
John Frame was the physician.
The other one, that's right.
But John Fuller was the author of the book.
Okay.
I read that.
Yeah, right.
And I said, I want to do virology. It was
Bingo.
a riveting story.
Interesting.
Right.
Interesting.
But,
yeah.
And that was after I had graduated. I was home. I was working as a lab technician doing microbiology, trying to figure out what to do. And so it's,
Apparently you found your direction.
Yeah, I'm still looking. I did find what I wanted to do.
That's right.
I was my father, who was a physician, wanted me to be a physician. Yeah. And the reason I didn't have anything to do after I graduated college was that I couldn't say no to him, yet I didn't really apply myself and didn't really even try to get into medical schools. But I ended up finding what I didn't know what I wanted to do. I found it, and then many years later, when he was very ill, he came to visit the lab, and he said, "Well, I'm glad you found something on your own." It's good.
Right.
Yep. Anything else before we move on to our paper here?
I did want to say one thing about the email also, and then one of them suggested that direct contact with cat feces is a no-no, and it's not true. Direct contact with the cat feces is fine as long as you don't lick your fingers afterwards. You still have to ingest the oocyst present in cat feces in order to get infected. So it's not just direct contact. It doesn't penetrate your skin, in other words.
Yeah, and it does require there's a 24, 48-hour period of time before those oocysts become infectious.
That's right.
I did mention I was going to say something about the Brazil. Because Brazil actually has that. We had a writer who mentioned they're originally from Brazil, and Brazil is a particular hotbed for toxo. Yep. And unfortunately, why is it such a hotbed? If you look at the high socioeconomic, the rich people, we'll say in Brazil, they have a very similar toxo pattern to we see in the U.S. Low percent of the population has it. It's a big problem because that percent can get infected while pregnant. You can get the congenital. The poorer population has a very high, in some areas up to 80% are toxo positive. And they've traced, and a lot of this is contaminated water. And so this stuff is actually getting...
That's right.
So because I originally, when I heard about this, thought it was, they're eating the raw meat. But then when they saw this pattern and then did these studies, unfortunately, the runoff... So
we actually discussed this when John Boothroyd was here as a guest, the involvement of Toxoplasmosis in the reducing population for sea otters on the West Coast from agricultural runoff from wild cats that also integrate into the farm scene, which of course is going to change because of this drought that they're having. But the sea otters might get saved as a result of this drought. Wouldn't that be an interesting consequence?
Yeah. Let me just briefly mention these two follow-up emails that I forgot. One is from Anne, who wanted to write to us for a while, now finally doing so because of something mentioned in number 90. I was in Hopeland, California, busily obtaining blood samples from western fence lizards while listening to your podcast when Dickson mentioned that reptiles get malaria. As it turns out, I was taking blood samples as part of a long-term saurian malaria research project I've been working on since 23. I study Plasmodium mexicanum, a lizard malaria parasite that uses 2 species of Lutzomia sandfly as vectors.
Huh.
I was so happy to hear you mention lizard malaria that I had to write in. If you ever want to chat about P. mexicanum, I'm more than happy to oblige. This is a fascinating parasite.
I could send you a picture of my western fence lizard if you'd like.
Maybe we should have her on to talk about what she's doing.
Sure, that would be
Also,
interesting.
I was interested to hear Vincent's thoughts on viruses infecting red blood cells. As a PhD student, I scanned hundreds of lizard blood smears and sometimes found small purple-stained inclusions within the red blood cells. I was told that these were viral particles. It appears that viruses can infect nucleated red blood cells.
Oh.
So she sent a reference to this paper from 1993, Lizard Erythrocytic Virus in East African Chameleons, where they say there are viral particles in the red blood cell.
East Africa, that's Madagascar.
Whether they're replicating there or not, I don't think we know. It may have inherited them from the precursors who were infected, right? That's possible.
Mm-hmm.
And that's interesting. Thank you so much for your podcast. It is refreshing to listen to scientists as passionate about parasites as I am. I teach microparasitology, invertebrate zoology, and ecology at Penn State, York.
Nice.
And often refer my students to your podcast and utilize them as discussion tools in class. I enjoy the addition of Daniel in the case studies. I've gotten all the cases except the one in number 90. I cannot wait for the big reveal. And is a assistant professor at Penn State, York.
Good stuff.
Is it Pennsylvania?
Yep. No, it's a branch of the
Penn
state
State
university system, yeah.
And then Steen wrote, in case you're still curious about the origin of the name Sijun,
Right.
it stands for ubiquitinated by FBW7, the target of the apicomplexin prolyl isomerase you discussed in TWiP 88. So it doesn't stand for it. Remember that it's ubiquitinated by this prolyl isomerase that we talked about. This putative cell-derived oncogene is termed Jun, abbreviated from Japanese Junana, the number 17.
Ah.
The gene was named after avian sarcoma virus number 17 by a Japanese fellow, so he called it Junana, which is 17 in Japanese. And see, Jun, how about that?
That's great.
Etymology as well as entomology.
Peter Vogt gives a perspective on the rapid identification of Jun as a transcription factor 28 years ago. We see how convergences of seemingly unrelated research leads to important insights.
It's all networked eventually.
Perhaps June 17th should be declared National Oncovirus Day.
Great idea.
That was yesterday.
Yeah, exactly right. We missed it by 1.
June because of June and 17th. That's
Yeah,
brilliant.
yeah,
I didn't know
yeah,
that.
Yeah.
Well, now we all know what C. June stands for, Dickson.
Thank
Because
you.
you're the one who always asks, what does that stand
I'm
for?
just curious, that's all.
All right, we have a paper that I came across last week while in Glasgow, and this was dinner conversation, and you will see why, because papers usually don't come up in dinner.
No.
And this is published in PLOS Pathogens.
Right.
It's called Cyclic AMP Signaling Regulates Gametocyte-Infected Erythrocyte Deformability Required for Malaria Parasite Transmission.
Right.
And the first author is Gania Ramdani, and the last author is Catherine Lavazek. And this comes from University of Paris, the Pasteur Institute, the London School of Hygiene and Tropical Medicine, and I have to say this one, Dipartimento di Scienze Farmacologiche e Biomolecolari Università di Milano, just because it's Italian.
Yeah.
And I found this really interesting, having read it.
Yeah.
This deals with an aspect of the life cycle of malaria about which I was unaware, and which I'm sure now we will have Dickson. So, Dickson, the malaria goes into the liver, then it erupts and infects erythrocytes,
Correct.
which have to go through a series of maturation stages.
You do.
And now explain this to me, Dickson. They say here that there's a reservoir of malaria in the bone marrow and other organs. And in order for these erythrocytes to maintain them, tell me if this is correct, to maintain in the blood so that they can be picked up by a mosquito and transmitted, they have to be flexible. Do you understand this? Because if they're rigid, they get stuck in capillaries in the spleen and so forth. Am I getting this?
Well, a little bit. I didn't either.
A little bit?
No. I'm going to tell you that for the years that I've taught this subject and listened to talks on malaria at various meetings ad nauseum almost, because malaria is a big topic and obviously it occupies a lot of space and time with regards to money and research, etc. So there's a real interest in this. I never knew that the malarial parasites as immature gametocytes were sequestered in the deep tissues, just like the infected red cells that have the merozoites inside, okay? So the merozoite, let's just talk about that for a moment. The merozoite, once they emerge from the liver, right, they can't go back in, so they now must infect their next host cell, which turns out to be erythrocyte. So they infect the erythrocytes in some very interesting ways. That's right, with CD55, etc. Yeah. But it's not the only part of the story, because they actually have a little organelle called the epicomplex, which is the front end of the organism, which they secrete things into the milieu, which allows them to then create this tight junction, which eventually encompasses them into a little parasitophorous vacuole. They then replicate inside that vacuole and then burst out and go into the next red cell. It sounds like a viral infection a little bit. You know, they have a factory where they manufacture themselves, and out they come, and they go to the next red cells, and there's a multiplicity effect here, right? But somewhere along the line, this parasite has to transmit itself to the next definitive host, which turns out to be the mosquito, right? So they have to build sex stages. This is a diploid organism that actually replicates in the host, us, as a haploid organism. But in the diploid stage, they have to be inside the mosquito's stomach in order for this to occur. So how does all that happen? There's no time to go into all of it, but what I never knew was that in order to make a gametocyte, it first of all has to sequester itself, just like the red cells that have these histidine-rich proteins on the inside of the red cell membranes that the parasites put there, which allows them to attach to the endothelial cells. The gametocytes, the immature gametocytes, also have a protein, parasite-derived, that allows the infected erythrocyte to sequester itself in the deep tissues. And in this case, it's in the lungs, and it's in the bone marrow, and it's in the spleen. And there, the parasite then develops to a mature gametocyte. And my guess is that at that point, it loses that attachment protein, and it is now free to move back into the circulation where it came from.
Now listen, it's not all about attachment, though, they say.
Right.
In fact, in one part of this paper, they say previous results have suggested it's not just about attachment, there's something else, and this involves deformability.
There you go, because to get out of the bone marrow, or to get out of the spleen, you have to pass through little pores. It's not into a capillary per se. Right. It's how you get out. So red cells are born to deform. They're born to deform.
Born to deform.
That's right.
There we go. We have our episode title.
That's right.
Just let Dickson talk and you get a title, right?
So, well, because red cells in general are bigger in diameter than the capillary, isn't it? So how does it work then? How do you get a red cell through a capillary?
They're bigger
and
than
the answer is the red cell deforms to supply maximum contact between the erythrocyte and the endothelial cells. So you get maximum exchange of oxygen and CO2. That's how that works.
Got it.
And it's pushed through by hydrostatic pressure, pumped through the aorta. That's why blood pressure is so important, right? Okay, so you've got deformability of red cells. All know about that. Normal red cells. These are normal, not infected, normal red cells. But it turns out that the gametocyte stage also has to be able to deform in order to get out of the bone marrow.
So there's some thought of using this as a drug target.
How about that? In other words, to prevent them from deforming.
Right. So then if they can't get into the blood, then you can't transmit them.
Exactly right. Assuming for the moment, and we'll come back to this, that they're all in the bone marrow. And this turns out not to quite be the case.
Right. There are many assumptions in this paper, actually.
Right. Because the paper that definitively showed that the immature gametocytes do mature in the bone marrow was done in Ghana using bone marrow-derived tissues from infected children. And they actually proved, using PCR, that the gametocyte stage is only, 90% in the bone marrow during its maturation process. And so that was published in 2014, by the way. So I'm excused for not knowing about this.
2014?
Yeah, that was a 2014 paper.
I was going to excuse Dickson. I was going to say, as he started off with that introduction about not being, is that this wasn't known that long ago.
Yeah. No, it was just
and
a
this
year.
This is recent
old.
that they've really
right.
pinned down. I mean, there was this mystery. How come for quite a long time after the mosquito bite and the initial infection, you don't see these gametocytes? What's going on? And then all of a sudden they emerge. And so it was this mystery that was only recently addressed, I think, with these molecular techniques of where is this gametocyte development. And it's a wonderful several stage development. I've seen these pictures that are classic pictures. Where was all this going? Where was all this going on?
Right.
And I think, as Dickson points out, we now know, all of us, we didn't know before, that most of it is occurring in the marrow, but there still is some in the lung, some in the spleen.
And a few percentage points worth in the blood also, but not much. But maybe enough to allow the mosquito to get infected. So that's and the other thing is that we had a history of looking at the other malarial parasites, right? Ovale and Vivax and Malariae, and they all mature in the blood. All of them. They don't sequester in the bone marrow at all.
This is falciparum, though.
This is the only one that does that.
And that's the major human one.
Yeah, it's the major human one.
Right.
So that's the reason why we just assumed, it's got to be in the blood someplace.
Yeah, sure.
But it wasn't.
So they have a cool assay. So this idea of flexibility, they've made a very artificial assay. And I don't know if the relevance of this to an animal, but we'll get to that.
Right.
So they have a column full of micro nanosphere beads, which are metal, right?
Yeah.
And they add the erythrocytes to the top, and they flow through, and they measure what comes out the bottom, basically, right? And if they're not flexible, they get stuck.
Exactly.
This is brilliant, right?
Exactly.
In a way. And if they are flexible, they come out, and they can either they can count them basically, or they can actually fix them and look at them, right? And you can tell a flexible one from not. What do you think of that assay?
I think it's valid, but I also think this needs to be carried forward, as you say, into animal studies. So aotus monkeys turn out to be splenectomized aotus monkeys are highly susceptible to Plasmodium falciparum. So they probably should be the ones to go next before you try to find this out.
So apparently there was previous suggestions that somehow an enzyme called protein kinase A was involved in deformability, right?
Right.
So that's where they start here. They use inhibitors.
That's right.
PK. Now PKA is an important kinase that regulates. It phosphorylates many different targets. It has roles in many different things.
It's a huge protein with multifunctions.
Very important.
That's
lots of different things.
That's right.
So there are two inhibitors they use, and they show that when you inhibit PKA, the erythrocytes that are infected with the gametocytes get more flexible.
Yes.
You see, this is a little tricky paper because you got to get all the...
You have to think in reverse.
So inhibiting PKA,
that's right,
you get more flexible.
Right.
So somehow PKA is its activity is important for being rigid.
Exactly.
Right.
So what does it actually do then, right?
Who knows?
Well, no, we do.
Sure. We actually know.
We don't know exactly what PKA is doing in this case to make them rigid or
well,
right?
If you go back and read the title of the article,
it
starts off with cyclic AMP as the first word.
Well, that doesn't tell you what PKA is doing, right?
Yeah, I would agree. I mean, cyclic AMP, as you increase it, it's going to increase your PKA. So PKA is downstream of cyclic AMP.
Oh, okay.
Yes.
We know that PKA phosphorylates actin and spectrin. I think we had that in our...
We do.
And we think that that's involved in this rigid. But, I would agree.
So these are structural components that if you phosphorylate them, you're modulating the flexibility of the red blood cell.
Exactly. There's a whole network of, you think of spectrin as creating a web just under the surface of the red blood cell membrane.
Right.
And it's anchored to the membrane through wonderful name, ankyrin. But then actin is actually binding across the spectrin. And this interaction can be controlled, and the stiffness controlled by phosphorylation. So you activate PKA, you increase this phosphorylation, you make everything stiff.
They use that word often in this
They
paper.
do.
But you could go back ahead and say, well, you know what? This is all sort of up above. This is cyclic AMP. You increase cyclic AMP.
That's right.
You increase PKA.
That's right.
You increase, stimulation.
So they then move to cyclic AMP because it's known to be upstream of PKA, right?
Right.
And you can raise cyclic AMP a couple ways. One is you can, receptor stimulation, or better, just prevent it from being broken down by phosphodiesterases.
Oh, yeah.
Oh, so if you phosphodiesterase will naturally cleave cyclic AMP and
True.
prevent it from activating PKA,
Yes.
right? And these
That's
phosphodiesterases
very cool.
can be activated or inhibited.
Yes.
Right? And they
So
use,
how many phosphodiesterases are there?
I think we know of,
Actually, I know the answer because I looked it up on Wikipedia.
how many did you come up with?
Well, they number them interestingly because we have a colleague in the next room who seems to be the guru for biochemistry of everything.
By the way, we're talking about falciparum enzymes
Yes,
here, right?
that's
Not
right.
red blood cell enzymes.
No, but you start with
Interest-
red blood cell enzymes first.
No, actually, that is. I hope I'm not interrupting.
Yeah, it's okay.
Interesting. We're talking about this rigidity occurring on both at the parasite, the gametocyte level, but
And
we're
the red
also
blood
talking
cell, yeah.
about occurring at the red blood cell level. There's
normal red blood cell
and
levels, that's right.
I noticed when I was reading this, I come across this word that I'm just, oh my gosh, they said that, and it was they say disassembly of the microtubular subpollicular network. And then they say subtending the trilaminar membrane structure in the transition. Yeah, I mean, I'm about to fall over. Now, that is actually the protozoan. A pollicular network sits below the pellicle, which is this thin layer that's in the protozoans. So part of what they're talking about is there's a rigidity to the gametocyte, but there's also a rigidity to the red blood cell.
And the use
So
of
everything is getting rigid.
and the use of the word subtending is usually applied to plate tectonic movements. So let's just be clear about that.
So the reason I mentioned they use a falciparum PKA gene to do some of their experiments, and they show that this can affect the flexibility of the erythrocyte.
Yes.
So unless that is also affecting the erythrocyte, which could be, right? It's not just that you're making the parasite more rigid or flexible. It's probably both, right? We don't really know. I don't think they can tell which is the cause of this.
Right. So at any rate, human beings have phosphodiesterase 1, 2, 3, 4, 5.
Six, too.
No,
Yes.
6.
Yeah,
then
they
there's
do
a
have
7.
Excuse me, it's in the paper here. They have 6.
Well, Wikipedia needs to be corrected then.
yeah, no,
because
in fact, 5 and 6 are inhibited by a very famous drug.
really? Mm-hmm. And that is, we're going to discuss that.
Yeah.
drug.
So there is a 5 and a 6. But are there
It's
more?
a 6. And then there's a 10. There's a
10.
7 and a 10. And I wondered what happened to the intermediate
The guy
numbers.
died.
No, Steve Goff explained it very clearly, and that is that the genes were expressed first and discovered, and they numbered them, and then they discovered other phosphodiesterases after that, and they never matched up the gene number with the phosphodiesterase proteins.
Anyway, so they show in this paper that cyclic AMP can affect filterability in their assay, flexibility.
Sure.
So if you have more cyclic AMP, you'll have more PKA, and you will have more rigidity, right?
Yes.
Because we said if we inhibit PKA,
Yes.
we get more flexibility.
Yes.
And so then they look at phosphodiesterases to modulate cyclic AMP. It's a kind of a natural progression, right? They look at stimulators and inhibitors. And some of the inhibitors include drugs that are used to treat erectile dysfunction.
Correct.
And they use actually not the trade names here, but what would you call? There's a chemical name, then there's a generic name, then a trade. So Viagra is a trade name. What is Viagra, the compound called?
Sildenafil.
Sildenafil. And that's not actually the chemical name, which would be very long. So we don't
That
use
that would be the generic name. And then there actually is a chemical. Yeah, which is
What's the other? What is Zapranast? Is that Cialis? Do you know?
Oh, let me see how it's actually.
Zapranast.
Sometimes if I look, sometimes
I like how it sounds.
I think it's actually Cialis.
So
Their brand name starts with a C, maybe. I don't know if Zapranast is actually used in humans. I don't know if that's...
as they say here, Dickson, Viagra or sildenafil is a inhibitor of PDE5 and 6.
5 and 6.
So it's double.
Okay. But not all of them.
Not all of them.
That's
They
the
are
point.
specific.
That is the big point.
I don't think you'd want to inhibit all of them.
Well,
right?
that
might have side
exactly.
effects.
You'd fall apart, right?
And the other one, let's look up Zapranast. Can we Google that?
We can. Okay, so Cialis is tadalafil.
Right. Should have learned that from the evening news.
So Zapranast never made it. It was a precursor to Viagra. It never made it to the market.
Okay.
So this is a very interesting story, which, this was, Viagra, of course, was initially made by Pfizer.
You bet.
And the story goes that the CEO of Pfizer went to his gym and he asked his personal trainer, we have this drug that cures erectile dysfunction. Do you think this would have any use? And he goes, are you crazy? You sell billions. Right. And the story also goes that Merck decided not, they had their own candidates. They decided not to because it wasn't appropriate.
Oh, my goodness.
Can you imagine?
Oh, my goodness.
Oh, my gosh. Wow.
So these are inhibitors of phosphodiesterase,
Yes.
and they would make cyclic AMP go up,
Right.
which would make
Other things go up.
But what it does, I think, is you need to think of as erection as an active process. It's a dilation of the smooth muscles.
Yeah, these are vasodilators, basically.
That's really what they
right?
are doing.
And in this case, they're looking at the effect of them on the rigidity, which, you couldn't plan for a better story, right?
It's really true. It's very marketable.
So they recommend
the parasite-infected red blood cell.
That's right. People with low blood pressure shouldn't be taking this drug because if you vasodilate, the pressure goes even lower. That's not good. So
they treat the erythrocytes with these Viagras, and they get more rigid, and they stay in their metal bead column.
Exactly.
That's really the bottom line here.
Yeah.
And what they say is it's a proof of concept, and I want to hear from Daniel. I mean, what are we thinking about here? We're going to treat malaria-infected people with Viagra and related compounds, and that's going to reduce transmission. It's not going to help them all that much, right?
That is interesting. And so the first thing sort of comes to mind. What are people going to take Viagra every single day?
That wouldn't be good, would it?
Now people do that actually.
They take it every day.
Every day. We use it specifically for pulmonary hypertension.
Is that right?
And they take it every day.
And do they take a different dose from that used to treat erectile dysfunction?
I'm actually not sure if the dose is different. I think it's actually higher, if I remember, for the pulmonary hypertension. I think the dose actually escalates.
Do you know if the doses they used here are pharmacologically relevant? I mean, I think they use millimolar amounts, which is certainly not, right?
I don't. Yeah,
actually,
that actually is a good question.
100 micromolar sildenafil. So micromolar is too high, isn't it?
I'm not sure. That would be that is an interesting question. Are these doses that we're obtaining when we give it? The other is not only Viagra, but you brought up Cialis. Cialis now has an indication for BPH, benign prostatic hypertrophy, and again, people are taking that on a daily basis.
So if you take this, you are constantly aroused, basically. Men, anyway.
That's a distinction that's important. This doesn't arouse you. It doesn't affect your libido. It affects the mechanics. You still need to. They say the distinction. Well, you still need to be aroused. You still need to be. And
so people with the dysfunction can't get aroused on proper stimulus, and this allows you.
This allows you to get aroused. Yeah.
All right. So it doesn't immediately.
It's not like you pop the pill and you say, "Well, what's happening?" There needs to be some cognitive, psychological aspect. But you could take these medicines can be taken every day. And as you mentioned, the whole question of, well, why would a person take this? Because it's not helping them. Yeah. It's preventing the gametocytes from getting it. It's preventing transmission. Yeah. But this might be a drug that people are willing to take for the community interest. Because they are getting some potential benefit.
What's the effect on women of taking these drugs?
Now, women can get, we'll say, increased engorgement, increased vasodilation of their sexual organs as well. Okay. But it doesn't have, maybe, as we discussed, the libido impact. But there is, interesting enough, there is a pharmaceutical company. It's privately held by women, for women, that I think they were featured in the Times not too long ago, that has a libido medication for women.
Correct. I saw that. Yeah.
Maybe there's a certain truth to that. Women, it's a much more of a psychological, and men, there's more of a physical.
Aphrodisiac-like.
But yeah, for women, the Viagra has not really say, done much or been received as any kind of an enhanced or as a significant enhancement. I'll sort of qualify
So
that.
one sociological consequence of pulmonary hypertension being treated with Viagra, it has the birth rate among
people with pulmonary hypertension gone up. No, but I think what they are, there is a suggestion here. If we can reach pharmacological levels that would actually maintain the gametocytes and the gametocyte-infected erythrocytes in the marrow, would this keep people from being able to reinfect the mosquitoes and spread it?
Right.
And the other thing is that since this affects that part, does this rigidity affect on human RBCs? If it's affecting the human RBCs, just the immune, does that affect other stages? Does that make them more or less susceptible to initial merozoite invasion?
I think it's important to point out that one of the controls here is that these treatments have no effect on uninfected erythrocytes.
Right.
Mm-hmm.
All right. So this is some more support for the idea that it's the parasite enzymes that are doing this, right? And that's good because you wouldn't want to change and the fact that these drugs don't have such side effects suggests that there's no deformability changes.
I have to admit, I was a little concerned. Let's say you have an infected red blood cell, and it's falciparum, and you're particularly worried about them becoming rigid and sequestering and causing a cerebral ischemia. Is that going to be a problem?
Yeah, right.
Because they're infected, they don't have the gametocyte. Is the same? Just sort of a safety concern. Are you going to make cerebral malaria worse?
Daniel, who should not? If this were licensed broadly for this use, who should not take it?
Well, as Dickson mentioned, people who have low blood pressure, people on. Everyone's seen the movie with
children.
Who's that famous actor that was in The Shining? Do you remember that
Jack
guy?
Nicholson.
Yeah.
He was in some movie where he had taken nitrates, or he took the Viagra, and then he goes to the ER having chest pain, and he doesn't tell them, and he gets the nitrates, and so you have to worry about things that might affect
children,
the blood supply.
Yeah,
that would be an interesting issue. Is what how safe is this in kids? I'm not sure. In all honesty. There's certain people have bad reactions, right? This isn't something you can just dump in the drinking water.
Dixon, this is done in a column.
Right.
Obviously, you need... What kind of animal experiment would you do?
Well, the Aotus monkey one.
Aotus monkey?
Yeah,
no mice?
Right.
You can't do falciparum in mice?
I don't know the answer.
So with a monkey,
you
would infect them and then let mosquitoes feed on them and see if they could transmit it to...
Or do treat Viagra with Viagra and then see whether or not the transmission is reduced. Because there are circulating immature gametocytes. There's a small percentage of them. They can't avoid all of them. But it may be below the limit for ingesting two, because you've got to ingest both a male and a female in order to complete this infection. So it could lower it down below the transmission horizon.
Interesting.
I was Googling a little about there's this growing idea of the humanized mouse, where you take this mouse and they're genetically modified and you put human cells into
Does
them.
that work for falciparum?
There's some work being done on it. I wonder if that could be used as a way. I'm not sure though.
If you can get mice infected with falciparum, sure, I would recommend it, but it's a difficult issue. That's why the Aotus monkey was so popular for a while.
Where do you get Aotus monkeys?
They're captured in the wild and then bred. Yeah, they're rather small, but they're a primate. No, not that small. Vince is making a motion with two fingers. No, it's a little bit bigger than that. It's about if you look them up on the internet, you can find them. But
what's the internet, Dickson?
The internet. That's
Aotus monkeys. All right, we'll put a picture of them.
Yeah, right. Right.
They say, Dickson, they call this the inverted silver bullet, as opposed to Ehrlich's magic bullet. So the magic bullet targets the parasite, and they say this is targeting the spread.
That's interesting.
Inverted silver bullet.
Altruistic. I would use the word altruistic.
So how altruistic are people?
Depends on who they are. If you ask Bill Gates Jr., perhaps they're very altruistic. If you ask the Cohn brothers,
they were doing. I think WHO was directing a phase 1 clinical trial of an Ebola treatment in Ghana.
Yeah.
I think it was a monoclonal, and the government halted it. They said, "We have no Ebola. Why should we do this? We're being used as guinea pigs."
Really?
Yeah. So it's unfortunate because they are at risk for Ebola. They have the bats that carry the virus. They've not had an outbreak, but you would think that...
No, there's a lot of injustices out there.
Dickson, if you lived in a malaria-infested region,
yes,
would you take this in a trial?
I'd sleep under a bed net for sure. And I'd worry more about it during the transmission season than during the dry season. So this may be an intermittent treatment, not a full year's long treatment. Would I take Viagra, period, no matter what? Well, I don't want to reveal much about my personal life.
I just wondered if you would take something.
I've never even thought about it.
That you would take something that would prevent infection of someone else that wouldn't.
Oh, yeah. I mean, that's not a problem.
So, Dickson,
for me.
I mean, Daniel, as a physician, can you imagine you're in your office saying to your patient, this drug will not help you, but it will prevent other people from getting infection?
Your children, for instance.
Yeah, it's unfortunate that people are not receptive to the idea that we live in a community and that some of our decisions are not just what is best for me, but I live in a community and we all as community members. And unfortunately, a lot of the vaccine arguments involved
herd immunity, right?
Appreciating the fact that, okay, I may not die of the flu, but if I get the flu, 10 to 20,000 people will die next winter because it's going to spread. And
that's right.
Some of us are altruistic. When my kids were of age for polio vaccine, there was a choice between Sabin and Salk, and I elected Sabin, even though there's a risk of vaccine-associated polio, but because I knew it provided better herd immunity, right?
Right.
Yeah. I'm willing to take that risk, but not everyone is. I understand. Anyway, cool paper.
Yep.
All right, let's do another case study.
Okay.
Right.
We got 15 minutes.
Bring them on.
As I told Vincent ahead of time off mic, this is a short, quick, I will say fun one again.
Fun.
Nothing bad happened.
It must have a good outcome.
Nothing bad. It definitely has an outcome. So that was and again these are all real. You can't make some of these up. I guess you probably could, but no. This is a case of a 28-year-old, I'm going to say mixed race man who has started his internal medicine residency at a hospital in Utah. This is not me. No. I actually trained out at Utah. I was out there for a while. I actually got engaged out there in Utah. It's a beautiful place, Salt Lake City. But this gentleman presents to their infectious disease clinic, and he tells his report is that he has worms. And he says that it was Saturday night, and he went out to one of these local private clubs. I don't know if our listeners
in Utah, you need to do that to drink, right?
I don't know if that's still going on, but you couldn't. There were no bars. You couldn't go to a bar. You had to go to private drinking clubs.
Right.
So he's a member at one of these private drinking clubs. And after a couple of beers, he felt poorly. He went to the bathroom and he vomited. And he noted something that looked like an earthworm in his vomit. He was concerned, and he scheduled a clinic appointment to come in and be seen.
Earthworm.
He says that's what he describes it as.
Got it. Earthworm.
So
it's a little bit different than the worms we're used to thinking about, but that's okay.
Do you want to ask more questions?
Well, there's got to be a lot more questions.
Can you describe that? What would you like to know?
Did
Dickson?
he recover this earthworm-like creature and bring it into the lab for examination?
So he did not. He flushed.
Oh, too bad.
He flushed the toilet with
how many worms?
And vomited.
How many are we talking about?
Yeah, how many of these things?
He just saw one.
Just
he
a
just
single.
saw one
Any
worm.
Size, dimensions?
He says it was a worm, right? We don't know.
Was it in the toilet before he threw up?
We don't know. He'd been drinking. He went to the club.
Did he say how big? Like a size of a pen or size of a... You're going like this, like Vincent goes like that.
I'm doing the like 5 inches.
5 inches?
What was he drinking?
He was drinking beers.
Oh, not tequila.
No tequila.
Oh, that's a good question. I like that. Sometimes they put the worm in
that's
the...
Right.
They do.
And they will challenge you to drink it.
That's right.
I don't know how big
it's not actually a worm. It's a grub.
It's a grub?
It's a grub that lives in the saguaro cactus, as I call it, the agave cactus.
It's highly fixed, so it wouldn't hurt.
It's very fixed. It's used as a temperance proof that if you drink, this is what will happen to you.
Okay, so he wasn't drinking tequila.
No.
So
he was
drinking beer.
Tequila.
Huh?
He was drinking beers.
Beers.
I said that. A couple of beers.
Right.
And was he eating at the same time?
He had some food.
What did he eat?
He had a burger.
Yes. What else?
Cheeseburger. Fries. Cheeseburger and fries.
And all of that came back to haunt him later.
Yes, and it all came up.
Okay, fine. So,
Yeah, and he went to the ID clinic.
He went to the ID clinic. Could we ask some questions now about the follow-up?
Well, do you want any more history or?
So this fellow,
If he didn't save the specimen, I'm not interested.
is he?
You will get interested, though.
I will,
Is
I'm
he
sure.
from the U.S.? Born in the U.S.?
Born in the U.S., from the Northwest, actually, from the Washington area.
Any traveling?
Extensive travel. He actually he reports extensive travel throughout India, Nepal, Southeast Asia. He took a year off during his medical training to do a lot of this traveling.
Mm-hmm.
He had actually come back to the U.S. Okay. Anyway, yep.
When he eats, what does he eat?
He's a pretty adventurous eater.
Pretty adventurous eater.
He reports being an adventurous
Has he
eater.
been well lately?
He said he's been well. He's an avid soccer player.
What color was this worm?
I'm curious. So he doesn't describe the color. So it was a lightish.
Was it moving?
It was moving.
It was moving.
How would we know if it's?
It's alive!
Was
No.
Okay, got it.
Now that's a hint that got me reinterested
That
in
piques
this
your
case.
curiosity.
He has no past medical history. He's a healthy guy. Hasn't had any previous surgeries.
Right.
He's
Daniel, when you vomit, what's the source of the vomitus?
where's it coming from?
Yeah.
It's
Mostly
really
stomach?
contents.
Not
yeah.
not intestine of any kind.
You know, if you could get a little maybe from the duodenum, the first part of the small intestine, that might have refluxed into the stomach, but it's really going to be a contraction of the stomach and an ejection of the stomach contents.
Bingo.
And when is the last time he traveled previous to this episode?
He had actually, so he's traveled a lot, and he'd traveled a month or so before he'd gotten back.
Right. And he's an adventurous eater.
He's an adventurous eater. He's a kayaker, hiker.
Right. And does he have regular checkups?
No, he
No, of
only
course not. He's a
he
physician.
shows up when he's sick.
Physician.
Well, at this point, he's training.
It doesn't matter. He's been to medical school.
You know, Daniel,
He knows to avoid them.
I don't think I need to ask my usual sexual questions, right?
You could ask him if
With
you
a
want.
worm, right?
You could.
No,
I
but
don't know.
ask.
Do you want to ask? Do you want to ask?
Ask.
What do you want to know?
Well, does he have sex?
Yes, and actually, he's got a nurse practitioner girlfriend, and they're
Okay. So he's
And they're practitioners. They're practicing.
They're in a monogamous relationship.
monogamous, and he is heterosexual.
Yes,
right?
he is heterosexual.
Not bisexual.
No,
Okay, and all right, that's fine.
he does drink,
Yeah, of course he drinks.
but no other toxic
Does he
habits.
practice protective sex?
Not with his.
Not with his long-term girlfriend, really. And does he have other partners, or
No,
is
he
he
does not.
unfaithful? No,
Not that he admits to.
Not that he admits to.
Not
right.
that he admits to.
All right. Okay.
That's it.
Right. A couple other things I'll tell you. His temperature,
Please.
he's afebrile.
Yeah.
Blood pressure 100/75. His heart rate's 50. His respiratory rate is 12. So the physician says, let's get you into a gown. Let's examine you.
Right.
And this is great. This is really great. So he's in the gown. He's being examined. Everything seems good. An 8 to 10 inch motile flesh-colored object emerges from under him onto the exam table. And that is actually obtained and sent for
Where did it
evaluation.
emerge from?
From his tail.
From his tail, his anus. Okay.
Yes.
Because he's either that or his mouth, right?
Yeah.
Can I ask, has he had a recent history of being sick?
No, he's a pretty active guy. I mean, he is he is working 100+ hours a week.
That's
Being
sick
a
in
medical
itself.
being a medical resident, so he's
Right.
sleep deprived.
So he's had no colds or fevers or that sort of thing.
but your normal stress of working
Normal
way too much and not
stress.
getting enough sleep.
So
and-
now out of both ends emerges something.
Yeah.
It's motile,
yeah,
5 inches long, and cylindrical in shape.
Cylindrical, right?
and motile.
I would-
motile.
We can't guess now.
Yeah, you can't
Keep it
guess.
to yourself.
You
I'm not
couldn't-
gonna guess
you
All
it
couldn't
right.
think
now.
about it.
I would sounds
But
like
the
you're gonna
light
guess.
bulb
Yeah.
just went on.
But I love the fact. I mean, this actually happened
On the table.
You're just like, really?
That's
So-
pretty funny. Both
Not
ends.
funny for him.
No, as a medical trainee, he was fascinated.
He was fascinating
That's-
is one
look,
thing.
Look,
Were his eyes
Funny is not.
Were his eyes normal?
his eyes were normal.
Right.
No, that's a good thing, and something we didn't talk about when we were discussing toxoplasmosis, which we say is normally asymptomatic. Is toxoplasmosis going to affect the eyes? And we're beginning to realize more often than was previously
chorioretinitis.
Yeah, it actually can cause damage to the eye.
Yes.
And has some recent publications on that.
Usually,
but this gentleman, didn't get.
but
I'll
not
say
always.
at this point, this gentleman has not had an extensive fundoscopic eye exam. But
when Toxo does that, is that because it's in the eye proper?
yeah, actually will
It's on the
invade
retina.
and cause inflammation in the
Correct.
back of the eye.
Through the circulation?
Yes,
Gets
it'll
in
come
there?
through
There
the
are no
circulation.
cells immune to attack from
Yeah, it's
toxo.
privileged. That's why this recent Ebola
Kiss and
physician,
spit.
he
Kiss and
had
spit.
he had Ebola in his eye. Remember? I don't know if you were here for that.
No, I
Yeah.
was here for that, and it's also in semen, so it's all over the place. No, it's everywhere.
In these immunoprivileged sites, it persists,
Interesting.
Wow.
Well, that's plenty of clues there, I would say.
Yeah, that's good.
You like that? Yeah, I think that's good.
Narrows it down quite a bit, I would say.
Daniel, in your experience, have you ever had a worm emerge during a physical examination?
No, and it's sort of good that this happened during this exam. Exam. Because often you get the story of I have worms, and you really are like,
sure.
I want to see them because you want to make sure they really have a worm and
Exactly.
not. So there have been a couple stories. One was the story of the guy who brought in a worm that he was a construction worker, and it was he was up on some higher level floor, and he noticed a worm in the toilet. Right, he brings it in, and it was an earthworm. And apparently, what had happened is he's a construction guy.
Yeah.
Somehow it had gotten in his pants, and so
Yeah.
it didn't actually come out. So you really do want to see these things. They do,
Dickson, didn't you once see worms emerging from a patient?
I didn't, but one of our medical students did, and it was a 4 or 5 year old girl who was part of a family from Honduras. And the mother had HIV/AIDS, and the child had HIV/AIDS. They both had malaria, and they both had something else.
Yeah.
And that something else was what emerged from this little girl's nose. And,
Yeah.
All right, Daniel, thank you.
that should leave everyone on the edge of their seats.
Yes, go start Googling and researching.
In Europe, by the way, I noticed that when I was traveling throughout maybe Germany and France, and perhaps not England, but so those other two countries, their toilets were constructed differently than ours.
Yeah.
In that there's a platform on which the solid wastes fall. The liquid wastes go down the front of the toilet, but the solid wastes sit there so that when you get up and turn around, you can look to see what else
What's
is
there?
in it.
It's cool.
And you can find things
Well,
this way
I'm not
sometimes.
sure it's so cool, but
It's
smart.
more
It's smart.
introspective. Let's just put it that way.
It's like someone pointed this out to me once. Most people, when they blow their nose, they usually look.
No, they do.
Jay Leno does that a lot on his. He used to do that
does?
a lot on his show. People would be poking their ears and looking. They would say, "Did he look? Did he look?" To pick their nose. Did they look?
Wow.
We're curious. We're just curious animals. We want to know everything.
All right. Well, on that note, we can wrap up this TWiP 91 as we are marching towards. We have 9 more episodes. That is like 4.5 months, right?
Maybe.
So this year,
Oh yeah, this year for sure.
if we keep doing it at this rate.
Absolutely.
You can find them all at iTunes and also microbeworld.org/TWiP. And we would like to get your questions and comments, even though we haven't read them in a while. We should next time perhaps read some of them instead of a paper again. TWiP at twiv.tv. I would like to thank Dickson Despommier for coming and participating today.
What an extreme pleasure to
Thank
be
you,
here.
Dickson. You can find Dickson at medicalecology.com, verticalfarm.com, Racaniello.org.
You bet.
He's just the website king. It's amazing.
Not really.
Daniel Griffin is here at Columbia University Medical Center. Thank you, Daniel.
Oh, it's a pleasure as always.
And thank you for reviving and rebooting TWiP. And you
Absolutely.
obviously please everyone.
Yeah.
And you're young on top of it.
A long,
Amazing.
productive life ahead of him.
I hope
you.
so. Again, thank you.
I'm Vincent Racaniello. You can find me at virology.ws. The music you hear on TWiP is composed and performed by Ronald Jenkins. You can find his work at ronaldjenkins.com. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP
is parasitic.